So this morning's presentation is an introduction to concussion case conundrum. It could be said that this year, in 2015-16, has been the year of concussion, from a Hollywood film that some of us may have seen, to class action lawsuits in the professional sports, to parents on the sidelines. So public interest in the topic has never been higher. Presenting an opportunity for a physiotherapist to highlight the important role that we do in the treatment and prevention of concussions. This presentation will use a case study approach to focus on three key aspects of complex concussion management. It's my pleasure, and beginning with Dr. Naznin Virji-Babul, on the role of imaging in concussion and some of the promising new findings. Dr. Virji-Babul is an assistant professor in the Department of Physical Therapy at UBC. Carol Kennedy, who's also here, will focus on the often overlooked role of the neck in concussion syndrome presentations. Carol has presented on cervical contributions to concussion-type symptoms on many occasions, including the medical symposium and workshop at the Vancouver 2010 Winter Olympics. And last but not least, Bernard Tonks will address assessment and management of dizziness and concussion. In concert with clinical practice, Bernard has instructed courses in vascular rehabilitation throughout Canada, as well as internationally for the past 15 years. So please welcome our presenters.
Thank you. Can you all hear me? At the back? Okay. I'm just going to see how this thing works. Okay, so just want to thank PABC for inviting me. It's great to be here, and it's great to see so many of our students in the audience. This has been really fun for me to do this case study with Carol and Bernard. It's really been a true integration of research to practice. So the format that we're going to use is we have a case description of a patient that I actually have seen who's been in our research studies. And this kind of gives me a little bit of advantage in kind of talking about some of the research that I've been doing in concussion generally, but also about this specific patient. And then Carol and Bernard will talk about some of the issues that are related more around this cervical area and vestibular issues. But I wanted to start by just talking about this patient. This is a 23-year-old male student who's had a previous history of 2 different concussions playing ice hockey. It's fairly typical, his presentation. He came to see me when he had his second concussion, had lots of headaches, blurred vision. He was noticing some neck pain within the first 24 hours. After a couple of days of rest, he tried to resume his activities and go back to classes, but he felt like he was still having a lot of symptoms. He went to a concussion clinic where he was told to rest and just stay away from any kind of stimulation. And this is very often what we see when patients come to us in our research to be as part of our research, is that many of them say that their physicians, their doctors have told them just to stay in a dark room and to rest and not do anything because the symptoms are, if the symptoms are getting worse. And I've had patients who have been in dark rooms for 3 to 6 months and are starting to actually go into a depression because of the fact that they've just been resting so much. So this was fairly typical with him. He was having trouble with reading, working on a computer, watching TV, and he felt like he was in a fog. And this is a complaint that I hear a lot. People say that they're just feeling like they're out of it, they're in a fog, they're not able to really focus that well. Having trouble with his memory, not being able to pay attention to anything, had a lot of hypersensitivity to bright light, and this is part of the reason why doctors often say to be in this dark room, and having a lot of issues with balance. So this is a fairly typical case, and I'm going to be presenting some of the research findings related to this patient, but also just generally. So what happens to the brain after a concussion? What's interesting is that we've kind of moved from thinking about concussion as just being a ding in the head to thinking, well, maybe there's something more serious going on in terms of what's happening in the structure and the function of the brain, to now realizing that the consequences, oops, I'm going to go back here, may actually be more long-lasting. So we know that when you have a concussion, there's a force on the head, that the brain is basically being bashed against the skull, on the front and the back side of the head. And we know that this is disrupting a lot of the white matter fibers. And this is the video that shows a slice through the brain. And what you can see here is how the gray matter and the white matter are moving separately. So there are tiny little micro tears that are occurring in the brain after someone's had a concussion that we can now, for the first time with advanced MRI techniques, actually are able to visualize these changes. So what I do in my lab is to try and look at both the structure of the brain and the function of the brain. We're not yet at the point where I can tell if someone's thinking about ice cream and sex, but we're getting close to that. And I'm really interested in what happens with recovery. So even though the symptoms may be going away after a few weeks or even a month, it turns out that the changes in the brain are actually much longer lasting, and I'll talk about that in a second. So that's the focus of my research. And so this is a slide that shows an image from diffusion tensor imaging, which is a fairly new technique, and it's a research tool. Carol told me to make sure I mention that we're not ready yet to bring this into clinical practice, but it's going to be there very soon. This is the work that we're doing at UBC, looking at how we can image the changes in white matter diffusion. So on the left, you see someone who, this is a slice of their brain of an adolescent who is an athlete but has had no concussion. And on the right side is someone who's had a concussion. Now, what does this show you? Well, qualitatively, what we can see is there's a lot more yellow in that picture on the right. And this shows that there's actually tiny little subtle tears in the white matter that we can now visualize on these kinds of scans. And one thing that you'll notice about this is that the yellow areas are all over the brain. It's not really focused on one particular part of the brain. So these are global changes in white matter that now we can actually visualize in the white matter of the brain. When we look more, do some more detailed analysis of this kind of imaging, what we see is that most of the changes are actually focused around the frontal areas, so in the corpus callosum and in the internal capsule. Now, initially, when we started to do this research, I was focusing on adolescents, and I had thought that this is because we know that brain development is not completed in the frontal areas until about 25 to 30 years of age. So it's good news for about half of us in this audience. But it turns out that this is actually across different age groups. So in adolescents and in adults, we see that the frontal lobe is actually quite vulnerable to injury. And most of the studies now are finding that there are changes in the corpus callosum, the bundle of white fibers that connect the two hemispheres, and the internal capsule. And this is what we're seeing here. So we know now that there are changes in the structure of the brain, but we also are starting to recognize there are changes in the function of the brain. And one way that we study this is to look at the brain during the resting condition. And we used to think that when you were at rest, hopefully not right now, when your brain is not at rest here, but that there wasn't much activity happening in the brain. But we now know that almost 80% of the metabolism of the brain is used up during the resting condition. So this is really a very sensitive way to be able to look at what's happening in the brain and the changes in connectivity. And what I mean by that is just in terms of how different parts of the brain are talking to each other. So what we do in the lab at UBC is to bring people in, like this patient that I described earlier, and put on an EEG cap and just record 5 minutes of resting activity. And we now have, I don't know if this video will play by itself. No, it won't. Okay. I'll just go back. That's okay. We have now, with some of my engineering students, developed a neural network. And what this network does is it takes the activity all over the brain, just over 5 minutes, when somebody is not doing anything, and it looks at the patterns of activity all over the brain and classifies whether somebody has had a concussion or they're in the healthy control group. So we're now at about 85% accuracy in being able to detect whether someone has had a change in their brain in terms of the functional activity of the brain as a result of the concussion. And this patient that we described fell into this concussed category. Now, the last thing that I want to talk about is a very new MRI technique that has been developed at UBC by Alex McKay and his group. This is one of the most exciting areas, I think, in concussion, and I wanted to share this with you because we have data on this particular patient as well. And this technique is called myelin water imaging. Now, why would we study myelin? Well, if you look at the axons there, if you have an injury to the axon, as we know that's what happens in concussion, there's, of course, myelin that's surrounding the axon. So there would be a disruption in the myelin, but we've never been able to see this before. With this new technique now, I'll just go on, we can now image myelin for the first time in patients. And this particular patient who had a concussion had the scan. So on the left here, you'll see what a healthy control athlete looks like. And these yellow and red areas are visualizations of the amount of myelin in the corpus callosum and in the internal capsule. And what you see in this patient is that there's a lot less myelin. Now, we've always associated changes in myelin with MS, not really with concussion or TBI. And in fact, there's only been one study so far done by Alex Rauscher at UBC that's looked at changes in myelin in hockey players. So what you see here is that there's a lot less myelin in this person who had the concussion in the corpus callosum, which is the first arrow, and also in the bottom, which is the major forceps. This is the bundle of axons that actually connect the two occipital lobes together. So you would expect, given this kind of imaging results, that this patient would have changes in attention, in anything to do with information processing, first of all, because the corpus callosum, the information going from the two sides of the brain, is now impaired because of this reduction in the myelin. But you'd also expect changes in visual information, processing of visual information, balance changes as well because of these changes. The internal capsule also shows less myelin, so there's probably going to be a lot of motor-related difficulties as well. So this kind of imaging is going to give us a clue about what kinds of symptoms and signs that we expect. And we know that a lot of the patients who come in with this kind of symptoms and these kinds of changes are actually reporting that they're feeling like they're having trouble focusing on tasks, that they're having trouble with their balance, trouble with integrating information. And all of this kinds of symptoms, we can now go back to the imaging findings and see that there actually is a connection between what's happening in the brain and the symptoms that they're showing. So Carol is now going to talk about some of the next symptoms from this patient.
Thank you. Oh, are you advancing that or me? Just leave it there. We got it. Okay. All right. So recently, a classification system has been proposed to try and subgroup persistent concussion disorders and therefore help to guide the appropriate treatment depending on which subgroup you fall into. In this chart, you can see the three main categories that have been suggested: physiologic, cervicogenic, and vestibular and vision. They lump together. There are also two other categories. Migraine maybe should be separated out separately, and also mental health issues are becoming a category on their own. You can see the mechanisms, the findings, and the appropriate treatments for these subcategories. If you look at the physiologic, you can see under mechanisms some of the brain changes that occur, and our lead speaker has already outlined some of these. And you can see that under findings, a physical stress test would be positive in this patient group, subgroup, and they would, their symptoms would increase as their heart rate increases. We're going to delve into the final two categories in a little bit more detail between Bernard and myself, but here you can see the summary of those subcategories. There are some patients that actually have overlapping symptoms between categories, in which case you're going to have to address all of them. We have to remember that concussion is a dynamic process, and it can be changing and evolving over time, and therefore our assessment and management also has to be dynamic. The concussion guidelines recommend that we do rest until asymptomatic, and this is probably valid in the very early stages. However, there is an important balance between rest and activation, and strict rest has actually been found to be associated with poorer outcomes. We can use aerobic exercise as treatment, same as Allison and Jack Taunton were alluding to earlier. It improves the cerebral blood flow, it normalizes the autonomic nervous system, and it's also really important for its positive effects on the mental health issues that are sequelae in really persistent concussion. Appropriate pacing, though, is crucial throughout the recovery process. So the big question is, when do we initiate exercise? Complete rest for more than just a few days is probably not helpful and likely harmful. Early, carefully monitored, moderate intensity rather than low or high intensity exercise has been associated with better outcomes. Most of the research is introducing exercise, graded exercise, at about 4 weeks, but some would argue that even that, it may be waiting too long. So for our case, he's now at 6 weeks post-concussion. He's probably had enough strict rest, and it's time to get going. So a sub-symptom threshold exercise training program could be implemented, and you'd use whatever form was least provocative of their particular symptoms. So the recommendation would be daily aerobic exercise at 80% of their threshold heart rate, so keeping things below symptomatic. That is done for about 20 minutes. And then this can be progressed about every 2 weeks, depending on tolerance. So let's move to the cervicogenic subgroup, and how can we determine whether the persistent symptoms that they're having, and we're particularly thinking of headache and dizziness with this patient subgroup. How can we tell if they're maybe at least partially or perhaps solely related to the neck? And we would, of course, look toward our subjective and objective examination. And so here's where I try in 15 minutes. I guess I probably only have 14 now to try and do what I do in a course that takes a day and a half. All right. So the International Headache Society says that there are no particular characteristic criteria for the diagnosis of post-traumatic headache. So perhaps concussion headache should be subgrouped further, and then appropriate treatment could be delivered for that. So I want you to just have a look at this list of various descriptors, behaviors, and other associated symptoms that have been linked to headache. And as you're going down through, think about which ones might be more likely part of cervicogenic headache as compared to tension-type headache or migraine, which are probably the three most common that we're looking at in physiotherapy practice. All right, that's all the time I can give you to look at them. So now, let's go on. Moderate to severe intensity is what's described in the literature, although I certainly see people with mild cervicogenic headache. Episodic, of varying durations, and they fluctuate, and it fluctuates according to the neck pain, if it's cervicogenic. I don't know why things have shifted here, but you can still read that. It usually starts in the neck. It's unilateral, and classically cervicogenic headache is described as side-locked. So if you have a right-sided right-sided neck pain, you'll have right-sided headache, and it will stay on the right side. The problem is if you have bilateral neck pain, you might have a bilateral headache. There is associated ipsilateral neck pain plus or minus shoulder and arm pain. It is aggravated by neck positions, neck movement, and they often complain of a stiff neck. And this one here, it's often associated with trauma. So there we have our concussion group. Nausea, dizziness, light and noise sensitivity, and autonomic symptoms are considered lesser criteria. They're less common with cervicogenic headache as compared to maybe some other types of headaches, but they can be present. So our case also is complaining of dizziness. And let's say he's describing it as an unsteadiness or an off balance. It's episodic and seems to be related to the headache behavior. So the same aggravating factors, so neck positions, neck motion, different postures aggravate both together. They often come on together, the headache and the dizziness, and they're proportional to the neck pain. So as the neck pain goes up, so does the headache and dizziness, either frequency, intensity, duration. So these descriptors, along with lightheadedness, disequilibrium, disorientation, are the behaviors and descriptors of cervicogenic headache as compared to other. And we'll say with this case that he also feels that there's no relation to exertion, which would make us think more of the physiologic concussion rather than the cervicogenic subgroup. Restricted active range of motion, particularly extension and rotation, has been shown to differentiate cervicogenic headache from other headache types. And you can see from the star diagram on the right that our fellow has reproduction of his right upper neck pain in pretty much every direction, but particularly on left rotation. Cervicogenic headache and classic of cervicogenic headache and dizziness are symptomatic hypomobile upper cervical joints, particularly the top three. In fact, if you don't have this feature, I think you should rethink your subclassification. You probably aren't dealing with cervicogenic. And our guy is presenting with a decrease in left AA joint rotation, as shown by the cervical flexion test, which has been shown to implicate the AA joint in cervicogenic headache. So abnormal motor recruitment and patterning tested with the craniocervical flexion test with the pressure biofeedback unit has been shown to be abnormal in cervicogenic headache as compared to other headaches and control. And it's also commonly impaired in post-traumatic neck pain. So our fellow has poor performance on this test with early and excessive activation of his right scalenes. And when he tries to hold the nod without the superficial assist, he has little tremors, which would suggest that the deep neck flexors are weak and he has poor dynamic stability. So strength and endurance of both the flexors and the extensors, not just the deep but also the superficial muscles, have been shown in cervicogenic headache as well as in post-traumatic neck pain. So our fellow has difficulty with higher load test. As you can see here, as he lifts his head up off the ground, he has the chin poking superficial muscle dominance with lack of enough deep neck flexor control to be able to maintain a nod. And he's unable to hold the inner range when you correct that position, and he has poor endurance on holding that test. Muscle length, tightness in the muscle groups, across all muscle groups, has been shown in cervicogenic headache, and our fellow shows the same pattern. Clinically, bracing with tightness of the neck muscles is also seen in the dizzy patient who is trying to avoid any neck movement so to not provoke his dizziness. So we see that tightness in that patient group as well. So postural balance and equilibrium is controlled by three systems: the somatosensory, which is the neck that we're talking about, as well as vestibular and visual, which Bernard is going to talk a bit more about. The abnormal sensory input from our articular and our muscle receptors in the neck, particularly the upper cervical spine, create a mismatch from the input that's coming in from the other two systems. And this mismatch can often give you this sense of dizziness, which is referred to as cervicogenic. Somatosensory function is impaired in patients with neck pain, regardless of the cause, but it's more profound in WOD patients or whiplash patients that complain of dizziness, more so than whiplash patients that don't complain of dizziness, more so than mechanical neck pain, more so than control. So all neck pain may show these symptoms, but more commonly in this sort of concussion neck group that we're looking at. It's across 3 areas: kinesthetic awareness or proprioception, balance, which we've seen can be part of the physiological concussion as well, and eye movement control, where I will overlap with Bernard. So proprioception is neutral neck position is not accurately perceived by these patients. They don't know where their head is in space. And they have poor head relocation accuracy when tested with a laser pointer, my high-tech laser pointer and target system in both the horizontal and vertical planes. Their relocation movements are jerky and searching, and they often tend to overshoot, which you can see has happened with our case in the bottom slide. He's overshot to the right on returning from the left. So this is with eyes closed. Smooth pursuit is the test of the ability of the eyes to stay focused on a moving target. And specific to the neck is the smooth pursuit neck torsion test. It's a test that's done in neutral first, the performance of smooth pursuit in neutral, and then you compare to the performance in a torsion position. And you torsion by moving the body underneath the head so that you don't provoke the vestibular system. We look for saccades, or jerky eye catch-up movements, reproduction of their symptoms, and if it's worse when tested in the torsion position as compared to neutral, that would implicate the neck proprioceptive system. So our fellow reports more of a dizzy feeling when you test him in the left torsion position, even though there were no saccades. Now, on to management. Keep moving here. Manual therapy has been shown to be effective for the treatment of both cervicogenic headache and cervicogenic dizziness, and there's good research to support that. Mobilizations can be passive, they can be active muscle energy techniques. Snags or Mulligan's mobs with movements have been particularly looked at with dizziness. Manipulation has also been looked at with cervicogenic headache. So any choice depending on what your skill set is. Soft tissue techniques can address the local muscle dysfunction input. Needling techniques have also been shown to be effective with headache in particular. We can teach the patient muscle lengthening exercises to address the tight muscles that we saw on testing. We can give self-mobilization techniques to maintain the range that we gain with our manual therapy. We want to start to change that impaired motor control system, so we use deep neck flexor and deep neck extensor recruitment exercises in various grades. In athletes, and particularly contact sports, as well as our heavier occupational situations, we want to add and progress into strength and endurance. And the supine head lift curl up continues to emphasize the deep neck flexors, and doing pure rotation and 4-point kneeling focuses on the suboccipitals, and they've been implicated for both cervicogenic headache and dizziness. Proprioceptive retraining, you can continue to practice with the laser pointer and target repositioning with eyes closed in both horizontal and vertical planes. And you can also use tracing of either an object or a maze to train eye, head, neck motor control. You can progress the difficulty by practicing this in the torsion position, as we have with this fellow here. Eye movement control is very similar to what you would do with vestibular rehab. So in the first case, head fixed with eyes moving is your smooth pursuit, and you might want to practice that in the torsion position. Eyes fixed with head move, or eye-head motor movement coordination type exercises. Balance mechanisms can be challenged by changing the base of support, by altering the firmness of the surface, and by removing some of the visual cues. And you want to progress this to something that's sport or occupational specific. On to Bernard and the visual and vision systems.
All right. You guys hear me okay back there? This is awesome. Thank you so much, Carol, for setting up this next section. Dizziness and concussion. So dizziness is a pretty common feature of a lot of concussion patients, as you're probably aware. When I'm looking at a little louder. When I'm looking at a dizzy patient, I'm thinking about assessing multiple streams of incoming information. So we're thinking about visual, vestibular, and somatosensory information in particular that are important as far as looking at what's happening in terms of the quality of information. Is it coming in a timely manner? Is it good quality? And then also, can that individual sort of integrate this? Is there a sensory integration issue or not? My second bullet there, differentiating between vertigo and dizziness. That's a really important criteria, particularly when you're interviewing a patient. In the general lexicon, vertigo and dizziness are kind of interchangeable terms, but clinically they're very, very different. So vertigo is essentially a subcategory of dizziness, if I can call it that. Vertigo is defined as the illusion of movement occurring in the environment that the patient perceives, but it's not actually happening. Okay? Not that any of you have ever had too much to drink, but if you've ever had the bed spins, that's a typical form of vertigo. Okay? So patients need to be able to describe this. Dizziness in general is a purely subjective phenomenon. So we have no objective measurements of dizziness whatsoever. So clinically it becomes a challenge to kind of tease out of the history what that patient's trying to tell you. Any history of vertigo, any suggestion that they may have experienced that illusion of movement occurring in the environment would suggest that something abrupt and fairly acute happened to the vestibular system or something central within their history. Okay. The vestibular system is a funny-looking little thing. I have a special relationship with it. Met my wife through the world of dizziness, if you can believe that, and we're still together, so I think it's an enduring feature. That curly bit on the far side there, of course, is the cochlea, and that's responsible for hearing. The vestibular apparatus is made up of 5 sensory organs. There are these 3 semicircular canals, which are essentially those curly bits that you see, and then a central chamber. The semicircular canals, there's an anterior, posterior, and horizontal canal. They're responsible for encoding angular movements or turning movements of the head. They are insensitive to gravity, okay, but of course gravity is a pervasive force we all evolved with, so it has to be the role of that central chamber, and there's 2 little organs in there called the otoliths, the saccule and the utricle. They're responsible for encoding static head position relative to gravity, as well as all linear movement patterns, so forward, backwards, side to side. So between these 5 little sensory organs, you have a sense of where your head is moving through space, where it is relative to gravity, and that complicated task all information is relayed to your brain, integrated in a variety of anatomical areas. The superior colliculus is one that's pretty important, and the outcome, of course, is normal posture. There are 2 primary reflexes that, sort of motor reflexes that emanate from vestibular information. The first, as you're probably aware of, is the vestibular spinal reflex. We don't use that a lot clinically for assessment purposes. What we use is the vestibulo-ocular reflex, or the VOR. And the VOR is a critical kind of reflex force, coordinating eye and head movement, allowing you to have stable vision or good gaze stability with head movement. Okay? Alrighty. By the way, here's how I won a beer a couple of nights ago. The fastest reflex in the human, it's not going to work in your buddies here, but the fastest reflex in the human body, want to guess? It's the VOR. 14 milliseconds. So we're talking about a biological system that can bring in incoming information, process it, and put out a motor reflex in 14 one-thousandths of a second and be 98% accurate. It's pretty impressive. Okay, good. Vertigo is frequently the result of a sudden imbalance vertigo. You can get vertigo from central mechanisms as well. But in general, a lot of it comes from the peripheral vestibular system, and what it represents is a sudden imbalance from one side versus the other. So you have a neurological output, a tonic neurological output from both vestibular apparatus. If something disrupts that, if one side is inappropriately excited or inhibited in an acute manner, then the result is vertigo. Patient subjectively feels vertigo. You will objectively see nystagmus occurring most of the time. The patient can't suppress this in room light in the acute phase. And then there's usually some degree of nausea, depending on largely the patient and the severity of the pathology. Okay. Concussion patients are interesting because they may have had some pre-existing vestibular problems, because they're quite common, or they may have had a traumatic vestibular injury as part of their concussion. So it's always interesting to sort through these patients to see, maybe that's a pre-existing finding, maybe not, and that's where the history becomes important in terms of going back and looking for those sort of tidbits of information regarding things like vertigo. Okay. Common complaints around the vestibular world involve things like gaze stability. So if I move my head too quickly, I get blurred vision. Things may jump around. That's termed oscillopsia. Problems with motion sensitivity. Moving too quickly makes me feel dizzy. I avoid turning, particularly, let's say, to the right if I have a right vestibular problem. So faster head movements. Vestibular patients will tend to slow themselves down. They won't move quickly. They don't like turning their heads while moving, that sort of stuff. and then balance and postural control. So we tend to see quite a few problems with balance and postural control depending on the severity of the vestibular injuries and the concussion situation. Good. How do we assess the vestibular system? Well, we do a brief, the traditional vestibular assessment, and then I'll kind of get into how I've morphed it into a concussion assessment. Typically involves some oculomotor screening, so we look at primary and eccentric gaze, we look at smooth pursuit, saccade testing, that kind of stuff. These are all basically centrally mediated reflexes, so it's kind of a basic oculomotor screen. Then we go into looking at the VOR, the vestibular ocular reflex, in more detail. There's a lot of different ways of looking at the VOR, and but these two techniques I'm going to talk about right now, you don't need any particular equipment for. You can do it clinically without any special sort of setup. And that involves the rapid head thrust test and something called the dynamic visual acuity test, or the DVA test. These tests require no special equipment, can be done within a matter of minutes in the clinic, and they're very, very effective at picking up people with chronic vestibular hypofunctions, where one side isn't firing or both sides aren't firing on all cylinders. The Dix-Hallpike test, which some of you might be familiar with, is a basic screening test for the presence of BPPV, which is a particular pathology of the vestibular system that can occur after concussion, but can also occur primarily in an aging population. We do a motion sensitivity evaluation where we have the patient moving through a variety of movement patterns, and we get a bit of even though it is a purely subjective phenomenon, we get a bit of an idea of the severity and the duration of dizziness that's provoked by these rapid head positional changes. That gives us a really good idea of how to customize a program for the exercise program for that patient in order to temper the rehab programming specifically for them. Are any of you familiar with the Cawthon-Cooksey exercise program? No? That's a good thing. It should be sort of dying off by now. It's been around since 1947. We can do a lot better than that now. That's a generic habituation exercise program. What we're talking about here is creating a customized program specifically for your patient based on what they've told you in the assessment findings. Balance and posture control, particularly static and dynamic, so we'll look at some standard static tests like the Romberg, sharpened Romberg, and then we do lots of nice dynamic testing, lots of movement with walking with head movements, vertical, horizontal. Vestibular patients tend not to like that, as well as concussion patients too. On the right-hand side of the screen there is your basic head thrust test. The top part of that image is a normal VOR. So in other words, the head is being thrust to that patient's right-hand side. The eye should move to the left seamlessly, the same speed and distance that the head's moving to the right in order to stay on the examiner's nose in this case. The lower part of that image indicates a poor or compromised VOR function. As the head is thrust out rapidly to the right, the eyes do not generate the reflex and track to the left the same speed and distance. That would be a positive head thrust test. For the dynamic visual acuity test, we use a particular kind of eye chart. It's not that one actually, but it's something similar to that. We have the patient read the lowest line they can on the eye chart with their head still, right, which is static visual acuity, much like what an optometrist would test if you went to see one. And then we oscillate the head at a frequency of 2 hertz to start with and ask the patient to read the lowest line that they can clearly with the head moving. That's a test of dynamic visual acuity, and of course what gives the patient dynamic visual acuity is their VOR, okay? Normals can read the same line or the one above with the head moving. If they are reading above that, that's the clearest line they can see, that suggests compromised gaze stability. That could be due to central mechanisms, but frequently due to a peripheral vestibular issue and compromised VOR function. BPPV, how many of you have heard of this pathology? Yay, it's getting out there. This is the most fun pathology. Once you treat these successfully, it's highly addictive, I'll warn you. BPPV is rampant in an older population, so even though we're talking about concussions, I'm going to put a word in there. Over the age of 60, some studies are suggesting up to 30 to 40% of patients will experience BPPV. Over the age of 70, it's almost 50%. So it's extremely common pathology in an older population. In an under 50 population, the most common cause is head trauma, like a concussion. Okay, so at some point, you need to assess your concussion patients for the presence of BPPV, and that can be done fairly early on. This is a unique kind of pathology. It typically involves, I didn't mention the anatomy in detail, but within the otoconia, the saccule and the utricle, there are small calcium carbonate crystals. They're called otoconia, and that's what makes the utricle and saccule sensitive to gravity. In this pathology, some of those crystals we think slough off, break off the system, and wander into one of those canals, one of those semicircular curly bits where they're not supposed to be. When the patient moves their heads in predictable patterns, lying down flat quickly or rolling from side to side, looking up or looking down, that will trigger this burst of vertigo and nystagmus and some degree of nausea in the patient. Okay, so that's kind of BPPV. they pretty much will tell you. If you're a patient that says, well, I can't lie flat, I need 2 or 3 pillows, I never lie on my left side, if I roll onto my left side, I get dizzy, that's a patient who's essentially suggesting to you they have BPPV, okay? Worth the screen. I use a camera system like this. This is a particular model that we use, or I use, to capture imagery around the eyes, looking for nystagmus in both vestibular hypofunction patients as well as the BPPV patients as well. I brought some lovely video. This is the most typical variant of BPPV. So this is your classic posterior canal, free-floating debris kind of patient. This is a problem that can be resolved, 100% resolved, typically within 10 minutes in one session. Okay, so we can get rid of this patient's problem with, if they've got it. Fiona, can you play that video? I don't think I can do it from here. You have to just, down at the bottom, there should be a little.
1, 2.
That's into the Dix Hall pike, which is the test position. This is a
And
latency
eyes open
period
as much as
occurring.
you can for me there. There'll probably be a little bit of a delay.
Yeah, there we go.
There it comes.
There we go.
Okay. I've got you. It won't last for long. Right torsional. Yeah, it is your right ear. That's exactly what you've got happening. Eyes open as much as you can. You can blink now and again if you have to. Super.
What just happened there?
Is it gone?
Mm-hmm.
Uh-huh. Okay, so this is the most typical variant of BPPV. There are a variety of variants. The most common one is where you have free-floating crystals at otoconia in a posterior semicircular canal, and it looks just like that when you test it. Okay, there's a degree of latency before the symptoms and signs come on. She says, oh, it's coming, it's coming. She's referring to the vertigo. The vertigo and nystagmus occur at the same time. Okay, and what's actually happening here is these crystals are floating down through this thick column of fluid, endolymphatic fluid. It creates a pressure change, bends over a cupula, which has little nerve fibers attached to it, changes the firing rate from the posterior canal, which is an inappropriate excitation because there's nothing being inhibited on the left, and the patient experiences this nystagmus vertigo, which is relatively short in duration. Okay, so we'll talk about how to treat that in just a sec. Okay, so the hallmarks of vestibular rehab, adaptation exercises. So these involve exercises that are designed to improve VOR function, decrease gaze stability, and allow the patient better vision with head movement. They're extremely effective. They're one of the hallmarks of vestibular rehab programming. How they work is a little controversial, but they work very, very well. So that's a basic exercise program. Habituation exercises are designed to mitigate or decrease motion sensitivity. So when you have patients that have problems moving into certain positions, be it work-related, sport, or even just basic ADL positions, we can customize an exercise program for them, give them some guidelines about how to do it, and typically for a basic unilateral patient, 2 to 3 weeks, and they're going to be much better. Concussion patients tend to be a little slower, and we need to be a little more careful in terms of how we prescribe this. Okay? So the hallmark of habituation exercises is symptom provocation. The idea is to provoke symptoms in a controlled manner so that their brains can compensate over time and decrease the motion sensitivity. That becomes an issue for concussion patients where we're going to be more careful about provoking symptoms depending on where that patient is in the scheme of things. Our case study was 6 weeks into it. I would not be pushing habituation exercises at 6 weeks. That's a little bit too early for a lot of it. I'd be pushing adaptation exercises if necessary, that kind of thing. But the habituation ones can be quite provocative for patients. Balance and posture control exercises, sky's the limit. Walking with head movements, all kinds of different things. We have visual vestibular integration exercises. We have them looking at targets with head movements. These are all exercises that can be started fairly early on in a concussion population. Once again, tempering it, the prescription of exercise, tempering that with the symptom provocation that's going on. Particle repositioning, if this concussion patient does have BPPV, then we'll do a techniques like the Epley's maneuver, which some of you might have heard of. There are about 6 or 7 different techniques that we'll utilize depending on where we think the problem is and the nature of the problem. They're typically highly successful with about a 93% success rate with one 10-minute application. But most of these techniques, if you're up around 98% success rate with 3 applications. So they're pretty good to use. I've simplified my references, and you'll see at the bottom of the screen there. What I've done is give you the references for the 2 gold standard textbooks for the vestibular rehabilitation world and for the visual rehabilitation world. So rather than sort of putting a whole bunch of articles in there, which is a good thing to do, I've just kind of encapsulated it that way. So that's the vestibular side of it, which is generally where I've come from. And recently, in the last 4 or 5 years, I've fallen into the vision side of things, which has proven to be a tremendous boost to my practice and a lot of help to a lot of my patients. Vision's interesting. So we tend to think of vision as being more of an eye issue. We think of the eyes. It's actually a mental construct. It requires a lot of energy and effort to produce visual imagery. Okay? Vision occurs in the brain, but it's facilitated, of course, by the eyes. There are diffuse areas throughout the cortex that are involved in visual processing to some degree and integration of that information. So it stands to reason that if somebody's had a concussion, a brain injury, it's quite likely that the vision system's been affected. And in fact, that's what we're finding very, very commonly. Okay, so here's the tricky part. Patients with visual disturbances, my concussion patients with visual disturbances, like this case study, don't come and say, I've got a visual problem, or I can't see clearly. Sometimes they do, but mostly they don't. There's a whole pile of things that can be visually driven that are fairly covert, okay? Headaches, big box stores. All I have to do really is say, can you go to Walmart anymore, you know? And they'll say, no, I can't handle those environments, you know, the bright lights, the noise, the complex visual world. Not a good situation for them, okay? Bumping into walls and furniture, spatial orientation issues, nervous, anxiety when I walk down the stairs. Anxiety is one of the leading issues within my patient population, and it's such that now at the clinic we have 2 psychologists, and I'm pretty much keeping one busy just by myself. I see him after work, but I'm not seeing him all day long. Anxiety is a big issue. Anxiety has been related to a poor prognostic outcome in a concussion as well as vestibular population. You have a patient with a lot of anxiety, you're going to have some trouble unless you're going to address that. And we tend to use mindfulness techniques as our basic approach. Backing up the car. You know, so I have a patient right now who's a naturopath, doesn't believe he's had a problem. He comes in, he says, I think maybe you're right, Bernard. You know, I backed into something the other day. I just not used to doing that. I'm not, spatial orientation, depth perception is an issue, okay? Frequently feeling dizzy, can't go to the movies, can't go out, can't do all the things that we like to do. This leads to tremendous social isolation, okay? And what does social isolation lead to? Depression, mood disorders, which is already rampant, as Naz and Carol have alluded to, in a concussion population to start with, okay? So it can be really difficult for these concussion patients. You know, they get told to rest till they're asymptomatic, and then they typically do that, and they get depressed doing that. And then they try going out and hanging out with their friends and going to social situations, and that, they can't do it, they can't tolerate it. And then they get even more depressed and upset and anxious about the whole situation. Not so great. We've known since how's my time? Well, I'm doing okay. You guys were generous with the time today, thank you. We've known since about 1968 that visual processing is bimodal. So there's a spatial or ambient system. This is from some primate studies. I quite forgot the name of the researcher, but I can give it to you later. The ambient or spatial system and the so-called focal system of visual processing. So we have these 2 kind of systems that kind of coexist. We'll shift back and forth between them. We'll use the ambient system in certain scenarios and the focal in others. The ambient system is all about orientation of verticality, posture, and balance. So where is it? Where am I in relation to what's going on in the environment? The focal system is much more detailed and specific, what you would tend to think of as being vision, writing, paying attention to detail, those sorts of things. So there's these 2 systems that coexist. The ambient system is responsible for about 20% of visual processing. The focal system sucks up the majority of it. It's about 80% of visual processing. It's slower, it's more reactive. The ambient system needs to be really fast, okay? So the spatial system or ambient system is proactive, lightning fast, subconscious, diverse in the brain, larger impact on balance and postural control. The focal system, very different, slower, more detailed, more specific, and it's sort of secondary to some degree to the ambient system as far as balance and posture controls go. Okay. These are key skills for all of us, and they're particularly key skills for a brain injury population for a concussion patient. The ambient system or spatial system allows release from focalization for movement. In other words, it allows us to discount or inhibit to some degree the focal system to allow us to move more freely and to do the things we want to do in the environment. Relationships to verticality, that's a pretty important skill. Frees up higher level process from postural organization and control. This is a big thing I see in my population. They are fatigued, they're exhausted. Any concussion patient will tell you this. I just can't handle the fatigue. It's 1 o'clock in the afternoon, I have to rest. Why is that happening? It's happening because they're consuming vast amounts of energy to perform cognitive and processing integration tasks that they were fairly effortless before, okay? So the problem with a lot of concussion patients is, as you can see where I'm going with this, they tend to discount or inhibit, I don't know why, we don't know why this happens, the ambient system, the focal system becomes more dominant, becomes used for postural control, but it's slower, it's more energy rich, and they end up spending lots of time and energy trying to rationalize it. Okay. Cognitive function. Vestibular patients, irregardless of concussion, will tell you things like multitasking, memory, concentration are a big issue. You add the concussion into it, and it becomes amplified and multiplied many times over. So overall cognitive function through the visual system suppresses background information to allow to attention. Well, guess what? If you go to Walmart and you can't suppress background information, that's a big problem for you, okay? It's difficult to pay attention. It's difficult to have your postural control and balance working in that sort of very busy, complex environment if you can't suppress the background information. This might be a new term for some of you, but pretty much I tend to see a little bit more of my concussion population, much like this case study, is skewed a little bit more towards the post-concussion syndrome population. So heading out towards 1 to 2, 3 months out, or longer, years sometimes. A lot of my patients have this particular problem, post-trauma vision syndrome. Are any of you familiar with this? Yeah, good, awesome. Okay. So this is a term that's been utilized to kind of encapsulate a constellation of signs and symptoms. This term comes from the neurooptometry population and their work. There's a group called NORA, which is a wonderful group in North American Optometric Rehab Association that is pioneering a lot of this work. So post-trauma vision syndrome could be a bunch of stuff. Not all of this, but a combination of things. Eyes drifting outward, which is esotropia. You often see that. Excuse me. Binocular dysfunction. The eyes aren't working together very well at all. Double vision, blurred vision. Light sensitivity is so common. Noise sensitivity is also common in many patients. Concentration difficulties, visual field loss, reading problems, spatial judgment, spatial depth perception issues, and this concept of visual midline shifting. This is a very profound problem when it does exist in concussion patients and requires prism glasses, which we don't prescribe. Obviously, we have a neurooptometrist that will do that. But it's really the only way to correct these visual midline shifts that occur. The key factor with post-trauma vision syndrome, and this is 85% of my population right now, is this concept of overfocalization. For whatever reason, they have tried to adopt the focal visual processing system as their primary tool for maintaining balance and posture control. It's not working very well for them. Okay, it's a big problem for them. So detail first, spatial system comes second. Some patients sort of really almost blow out the ambient spatial system altogether, and they're just using their focal system primarily. Movements in the periphery become detailed. This is incredibly interesting. Don't sneak up on the patients, but what we do is a manual field, which I would do with this case study, for example, come up behind the patient and just bring your fingers into their peripheral field of vision and then wiggle them gently back and forth. There are some patients who almost have a violent response to this. It is so agitating and stimulating for them. So their peripheral vision, which should be an ambient sort of process, becomes focal. So everything in the periphery becomes extremely detailed. It's a terribly difficult way to live. They have trouble releasing fixation, and they have trouble switching between the focal and spatial systems, or difficulty using them simultaneously. I've got a little bit of time, so let me get you to stand up for a second. I want to show you this focal visual system. So if you don't have to do it if you don't want to, but stand up for a second. All I want you to do is just stand on one leg. Get a sense of what your balance is like standing on one leg. Nice work, Kevin. Okay, perfect. Okay, go back to two. Now what I want you to do is, listen carefully. I want you to close one eye, create a little tiny hole with your hand, pick a little target, something to look at. Okay, make sure your other eye's closed, make sure you just got as small as possible, and then try standing on your leg again. No, you got to have your fingers right up close to your eyes, right up close. Is it a lot harder? Yeah, great. Have a seat. What happened there? Well, I asked you, when you stood on one leg without doing this funny little thing, that was your ambient system working. Okay? When I asked you to stand up and do this, I forced you to use your focal visual system for postural control and balance, and it wasn't that successful. Okay? That, in a nutshell, is what a lot of concussion patients are going through in terms of their visual processing. Okay? So how do we look for this kind of stuff? Well, we do a pretty comprehensive vision screening. This can all be done clinically in the clinic without any special tools or any particular equipment whatsoever. We do cover-on-cover tests looking for strabismus or alignment problems with the eyes. So you can have the eyes drifting in and out or up and down, depending on the pathology that's involved. Looking at fixation, so having the patient looking straight forward, looking 30 degrees, it's called eccentric gaze, off center. They need to maintain that for about 10 seconds and you need to look really carefully to see whether there's any nystagmus there at all. If you see nystagmus occurring with fixation, barring an acute peripheral vestibular problem, you're looking at centrally driven nystagmus. Something's going on in the central nervous system that's driving that nystagmus. Okay? Saccades, horizontal and vertical, and smooth pursuit or tracking. So when these systems, these are centrally mediated systems, when these systems are down or in trouble, as Carol alluded to, these can also occur from the neck with the smooth pursuit system, you will see all sorts of jerky refixation, saccades, and all kinds of difficulties with targeting with saccade movements. It's not a good situation for your patients. Most patients get through the base reflexive systems okay. They start to have problems a little bit later. So convergence is a big one. There are multiple centers throughout the brain that involve convergence processing. This is the ability of the eyes to kind of move together, so binocular function. Many of your concussion patients are going to have difficulty with this. It's relatively easy to rehab. I'll show you how in a few minutes. If you pick this up with patients, it's easy to assess. If you find this in your concussion patient, you need to get them on appropriate vision therapy or rehab program, which I'll show you what it looks like in a second. Near-far accommodation, so have them read something close to them, have them read something in the distance, so shifting focus, right? So part of that's depth perception. If I'm reading something in the distance, my brain has to calculate approximately how far is that and then back and forth. So convergence issues, a recent study indicated that concussion patients sometimes are 3 times longer in terms of accommodation versus normals. Visual midline shifts we assess with just sort of markers. They get to tell us when to stop. If their visual perception is over here, if that's where they believe that their midline is visually, that's a huge problem for them. And clinically, you correct them with a prism, and it's virtually transformative within seconds. It just orientates them to verticality much more appropriately. We use colored overlays, binasal occlusion, testing for hemispheric dissonance. So we have them looking at right and left. Can they process right and left hemispheric information, visual processing information appropriately? You also have to, when you're doing this vision testing, you want to specifically ask for how effortful the task is. So, you know, there are many patients who can accomplish the tasks, but it's a tremendous amount of effort. Okay, to some degree, this is the basis of impacts via VMOS screening for concussion. I'm sure you're familiar with that. Visual motor ocular screen. So they essentially use subjective feedback. BNOs are kind of cool. I didn't have a lot of time to put that in, but this is where we take glasses. Excuse me, just regular, don't have the lenses in them. We put cloudy Scotch tape over the nose to block off the overlap of the visual field centrally. This has the effect of opening the ambient or spatial processing system, and it can be amazing instantly for patients. It's a great rehab tool. We can use it for a variety of exercises. Something we'd want to assess for sure. Okay, look at this poor lady here. Look at that left eye.
Hold that pin.
Is that converging? This is the biggest convergence insufficiency I've seen in about 2 years. Her right eye converges, her left, no. She fell and hit her head. She's a concussion. That's a massive convergence insufficiency. You cover her right eye and her left eye converges beautifully. It's not an oculomotor problem. This is a central processing issue. Okay? So when you see that kind of convergence insufficiency or more subtle, it's a big problem for patients. They should be able to get to about 2 to 3 inches from the center of their nose before the image goes double or blurry, or let's say not blurry, but double. And the recovery point should be about 3 to 4 inches away from the nose. Okay, just a rough idea of how we approach these problems. We tend to approach the problems from the basic reflexive systems on. So patients have problems with smooth pursuit, saccades, those are basic centrally mediated reflexes. So we'll give them some exercise programming, or may use the BNO, the little glasses with the cloudy Scotch tape, that kind of stuff. We work up to more challenging visual therapy, so vergence, accommodation tasks. We add cognitive load, which involves things like processing right and left hemispheric visual processing while they're doing other types of tasks. We'll do a lot of visual vestibular integration exercises. So these are very common ones. They're using visual targeting with head movement. So we're trying to integrate visual and incoming visual and vestibular information a bit more effectively. Motion sensitivity, as I mentioned, is more provocative. We'll tend to leave that towards the end a little bit. And things like photosensitivity. So a lot of these patients have problems with light sensitivity. We'll sometimes have to use baseball hats or particular shades of sunglasses, that kind of stuff if it's really severe. But hopefully it gets a bit better than that. So how would we rehab that lady with the big convergence deficiency? We do something called a Brock string exercise. So I'm just giving you a little teaser about some of the vision therapy stuff that's going on. The Brock string is just a simple string. They can make it at home. The hard part's keeping away from the kids, or the cat for that matter. It's simply a string with little colored beads up and down. These can be up to 3 feet long. They start at the nose and angle down about 30 degrees, and then the patient simply just focuses back and forth, up and down that string on those little visual targets. This helps very effective in retraining virgins in many, many patients. And these are cheap and easy things for them to utilize. Okay, so Brock strings. I think that's all I have, and we have some time for questions, I believe. Nope, okay. Thank you.